strip 直接上来啊。I know. But I went to sleep. 每天吃也都是睡了。当然大概会睡了睡了。但是我不太一样。
啊，这个是啊，谁教的水？
Yeah, 14, 14.
Which one is that? The LG. Oh, I have the old version. It's not out of yeah, they're trying to.
Okay.
Yeah, I bought that one for my wife. I was like, wow,
Yeah, really good. Like, I'm going to upgrade to one of those. Like, essentially, I want to wait until the price that I'm paying per month for this one. I'll pay for that one, but I
did switch to Project Pi, Google's provider thing. So it's way cheaper than AT&T.
Yeah.
What I have.
我不知道，我大概知道。
No, no, I'm just thinking when I was I like which one to get.
还有就是你要在国内借课，还有就是你要想办法去。
Let's send an email like
或者有些视频你要看。我不知道具体的具体的结束了。
You're super mom. Yeah, you still are super mom.
讲了之后吧，然后有很多都用说，这都是在讲，那不是他减去，这不是1295吗？减之后嘛，1295之后你可以通过这个，看现在到底该交多少税。1295在这里，看着这。这个是你让你交的，所以你还要有时候你要交1480，但你是要交但是我派。She only allowed me
70.
They require that you have the, like, she has to have the vacation time at the time she makes the request. Not, can't say, oh, in 2 months, I think I'll have this one. Just have it as an exercise. And then if she has to buy it nice, she gets ahead of time. Just they can't wait for that one and ask for it. It's already months. So I did this about because I had, when she asked me, I had it.
He's never gotten back to you on reviewing it. So you are aware that we aren't letting students present their mentor's that's a problem. So are you in the building? 20 minutes, so he's supposed to present right this moment. Are you able to log in remotely and introduce him? Okay, let's see if we can arrange for that. IT can reach you at this number? Or you know how to do that? Okay. He's actually sitting right next to me. I'll give you some of the phone.
Hey, Dr. Ishii. I'm good, sir. How are you?
Oh, no, just maybe just a little bit about the class and what you thought of my participation in your class last semester. Yeah, no problem. So you're going to dial back in?
The IT folks are right there. Hey. The IT folks are right there. They can help you dial in if you need to.
Okay. Hey, hang on just a second, John. I'm going to put you on the line with somebody that can help you dial in. Wants to dial into the session over here. Tell him how.
Yes, you're trying to dial into the session. So go to your that link. Where it says live seminar.
Those waters. Grab another one of your water. Thank you. That's okay. This is a
research seminar.
I actually figured this might happen, but this is a university problem. A lot of money can come to school here and they don't have it together.
And then research. And then there's no, it's on your computer, so make sure you mute yourself if you have to. Okay.
Thank you. All right, thank you. He's dialing in.
Okay, perfect. So he will introduce you and
Yes. Are you there, Jonathan? Okay, we're good to go whenever you are.
Okay, well, I'm here to introduce John Calhoun, a student of mine last semester. I know John has years experience working down at Austin Space Center during the shuttle program. And now he's now working at Indian Research on items related to informatics, and he does a lot of work with compliance department. A lot of my friends down in the compliance department around record systems that they're doing, and I will tell you if you look in my class, previous experience really helped in the class discussions when we talk about policy, because I know a lot of times when we have informatics related issues, a lot of focus is based on the research and the technical side of things, and not sometimes necessarily on the policy side of things. So I will now turn it over to John to give his presentation.
Okay, thank you, Dr. Ishii. So yeah, I am a little bit older than your average student, so I'm going to explain that as we go through the presentation. But this is not about like the announcement might have given you the impression I was looking for inputs on my research topic, and that's not the case. I am not, most of the folks here at the school really haven't interfaced with me quite a bit, so I wanted to tell a little bit about myself and a little bit about my research interest in this first presentation. So again, I am John Calhoun. See if I can get this thing to work. So I'm going to have to use the clicker. Okay, so part of doing that is I decided I wanted to share with you my experience through the journey that I've gone through actually to get here, and at the same time talk a little bit about the policy considerations that I think are important to driving certain informatics outcomes, specifically at MD Anderson. So you got the title. So what I really hope to cover here is just a little bit about myself, my academic interest and their relationship to the SBMI informatics and really to the SBMI informatics definition of what that really is. My pre-proposal research question, conceptual framework associated with it, and then a little bit about the practical implications of the work that I am doing. A little bit about the drivers for discussing current and future policies, government policy areas that drive informatics, tool design and development. And then I really wanted to talk a little bit about the potential academic policies that are important to actually driving that as well here in the medical center area. So with that, just a little bit about me. So you gathered from what Jonathan mentioned that I did work at NASA for some time, so you probably recognize the picture from me here. I consider myself informanaut, and you probably hear informatician more often than that, but I'm trying to tie it to my prior work. And then just a little bit about me, because folks really don't know me. So just briefly, I love things with wheels, so typically arguments with me are somewhat circular as well. I really like to learn, so again, that's why I'm probably a little older than your typical student. I have opportunities, depending on where I work, they've always offered educational reimbursement, so since I like to learn, I figured I'd take advantage of it. I did work at NASA for about 25 years, so this is me on one of the flights as a booster operator. And then I currently work across the street at the Institute for Cancer Care Innovation, specifically in a program called Enhanced Surgical Recovery. That actually has given me quite a few insights into informatics tools that I think are really needed on the patient end that aren't really being developed. And then again, I work across the street here at MD Anderson, and we're of course here in the UT Health Science Building. Now, a lot of times when I present and I talk about my background, people ask me why the transition from space to informatics. And interestingly enough, there's a really good connection. So I started out, as you saw, working at NASA, thinking about space, really loving engineering. My background was in aerospace engineering. And then when I decided to make the transition to bioinformatics, I got a master's here in 2013. People at NASA quiz me all the time about why I was making the transition. And part of the reason was I noticed after about 15 years, people always talk about a little bit about NASA translating things out into industry, and you don't often know what that means, but I could actually see the parallel with regards to bioinformatics. So there are many key failures associated with human behavior in space and space endeavors, and the same is true in medicine. And so a lot of the solutions I think that have been applicable to space really can be translated to some extent to the medical environment. And just to give you an example, the one that really intrigued me was eventually we're going to end up trying to send people to Mars. And if you think about that journey, you think that probably you're going to have 4 to 5 people on a vehicle, and if you're lucky, only one of them is going to be clinically or medically trained. And so in addition to all the other technology, of course, that you're going to have, it's going to be really important that you have the ability to transfer knowledge to individuals really effectively and really efficiently. So if I'm on board with you and I don't happen to be medically trained, how do I learn enough quickly to be able to treat you? Okay, and so there's ways to store data, there are ways to actually cover bias and other things for you to be able to do that. And then the other part is, again, we have a lot of problems with the asynchronous sorts of behaviors here on the ground, specifically with regards to you and your providers. So your providers are really all working in their own time zone, and the question is, how do you sync them all up? And this is the same problem that you face with space travel. Again, if you're on board the vehicle and you get as much as a 7 to 10-minute delay in communication, if a crew member gets hurt, somebody has to treat them, and they're not necessarily in sync with the ground. But when the ground actually gets a signal, you want to be able to translate to the ground as quickly as you can all the knowledge that you can, what transpired in that 10 minutes, so that the ground can actually help you, and then vice versa, sending it back up. And that's very similar to what we do on the ground with your providers. So your providers they're working in their own time zones, but what you as a patient really want is for them ultimately to get those things synced up. That's the last one. So then just a little bit again about my academic interest. So based on what I just told you, you might guess that my interest is really in methods for increasing the efficiency and effectiveness of knowledge transfer to support patient and provider decision making. And my specific research question is how can the concurrent design dimensions of a process-based tool affect that decision making and care coordination in cancer care? And again, I'm specifically focused on cancer care. You have a question, I could tell.
What does that mean?
What that really means is, again, so there's a lot of issues with.
Dimensions of a process-based tool.
Yeah, so let me explain it now or later. I'll explain it now. What it really means then is, so when you're into interactions with a provider, a lot of times there are things like time delays, or there are things like cognitive biases and innumeracy issues that have to be dealt with, and we don't typically deal with them very well as people. And so my premise is that you can actually consider those things in your tool design so that the tool actually helps you minimize the impact of that bias in the individual's decision making. Now, the question for tool design then is on what end of the axis for a given dimension do you actually design the tool to accomplish that? So conceptually then, what I'd like to go do is study how those dimensions, and I'll group them into three kind of general areas, which again is the time dimension, where your providers are not collaborating synchronously. There's the cognitive bias dimension, again, where people may have issues with numbers and probability and statistics. How do you help them make choices? And then the last one is innumeracy, again, which follows into that as well. And so that's really kind of what I want to focus on as part of the PhD effort. So no problem. So conceptually, again, that's what I just really covered. But practically, I really want to design a tool that does what we just talked about. And in fact, I not only want to design a tool, this is part of what I started when I did my practicum originally, so for my State of the Science paper. And you'll see a snippet out of that here in a little bit about what that means. So a lot of times when I think about what I want to accomplish, it's not really clear that there's a strong agreement about what informatics is. And so I thought I should cover that and cover the connection to what I want to do here. So our definition on our SBMI website is that biomedical informatics is the interdisciplinary scientific field that studies and pursues the effective use of biomedical data, information, and knowledge for scientific inquiry, problem solving, and decision making, motivated by efforts to improve human health. And so I have the part there in red because it's not really necessarily my area of interest in the definitions. So I wanted to give you the one that I really intend to focus on, which is that biomedical informatics is the interdisciplinary scientific field that studies and pursues the effective use of biomedical knowledge for scientific decision making, motivated by efforts to improve health. So again, I'm focused on the ability to effectively and efficiently translate knowledge from one entity to another, and in this case specifically to the patient. So I'm pretty sure that you guys have probably seen this chart before. Kind of covers the general topics that are involved in informatics. This is the area that I'm specifically interested in, which is clinical informatics and public health informatics. Although when you think clinical informatics, typically folks again think the provider end. So we're thinking about what the clinicians, the doctors, the researchers need. I'm really thinking a little bit more about it from the patient end. Within that clinical encounter, what is it that the patients need? I think I see sometimes that people actually have a sub-block under here called something like consumer informatics as well. Now, one of the things that I've noticed, and I've noticed it within the last 2 years that I've been at MD Anderson, as I mentioned, is that there seems to be this inequity between things that are developed for patients and things that are developed for the providers. And I think that's really for two reasons. Really, again, there seems to be a lot of focus on provider-focused tools. Right across the street now at MD Anderson, we just transitioned to Epic as an EHR about 2 weeks ago. And again, most of the benefit that we're going to ultimately end up seeing is on the clinical end, not necessarily the patient end. And then the next part of that really is this chart, and you might have seen this one before as well. It was from a presentation I think John Glazer gave as part of one of these areas, but it was one that really struck me as important for the things that we do in informatics. Because if you look at this thing, essentially, it says digital intensity and profitability, but it correlates with change management, and effective operational capability in healthcare or any other industry. Essentially, along the y-axis, again, is your investment in IT. Along the x-axis is your ability to actually manage change well. And so what it tells you is if you're in this bottom left quadrant, you can be investing heavily in IT solutions, but if you don't manage the change and integrate it well into the operational environment, it essentially does not work very well. And what you really want to be is here. Okay, so from there to there is what, about a 50% increase in your profitability or your operational capability. And that's really important when I come to something here a little bit later about what I see at MD Anderson. So again, if resource commitment is desired, policy direction is essential. So everything up to now was really kind of about me, my background, where I'd like to go. And the question then, and the same thing that I see across the street, is how can policy actually help us get to where I'd really like to be? And when I start this, then I think about the things that are driving the IT policies today. So unfortunately, when you think about where we're going with things like EHRs and information technology, even though we complain a lot about the government, typically it's what the government is doing that's driving entities to do certain things. And at some point, we have to assume that the government alone can't do it. So some of that effort has to be bared somewhere else. And I'm thinking it needs to be really in the academic environment. But how does the federal government do it? So this is really from the 2015 ONC strategic plan for IT. And they have 3 basic policy areas. So policies are not, again, the specific regulations and the rules specifically. It's just about the general approach to where you intend to head with your development ideas. And they divided it really into 3 areas: collect, share, and use, which I think from a policy perspective is a pretty good area to try to get people to focus on. So how do you do it in each one of those? So they have some things that they're trying to do with regards to collect, and if you thought about it, you can think about some of the rules and regulations that they put out to try to do this, and things like high tech and having people go to EHRs are things that are intended to drive people to collect information. Very similar, they're doing things to share information, so interoperability comes up quite often in this category. And then to use. So for use, you're going to see, again, within the healthcare industry, across different environments, but also you're still going to see using it from the patient end as well. And that's the area, again, that's not often hit as well. I, again, am specifically focused on cancer care. So what kinds of policies or things should we be doing with regards to cancer care? And a lot of it is connecting what's being done kind of at the federal level to what we ought to be doing kind of at the lower levels. So in cancer care, my specific areas of interest, and this is from the IOM Cancer Care Priorities, are provide patients and families with understandable information. So again, right now across the street, we do a lot of this with paper. You would be surprised at the amount of paper we use when a lot of this can be done very quickly with technologies that we have today. So in the Enhanced Recovery Program that I run as a project manager, with cancer patients, they're already kind of cognitively distressed. You can do things like just-in-time notification of things that we're asking them to do and integrate that well within an EHR, and it's very powerful in terms of a patient's ability to gather information, know what they have to do, and make judgments. And so I'll just skip through the rest of these. But essentially then, with regards to what the government's doing, what we really like to see is a balance between what we're doing on the healthcare practitioner end to what we're doing for patients and caregivers. And again, that's part of my goal. So how can the academic environment really support this? What's the academic policy contribution? Well, I again go back to the definition that we use for informatics, is what is it we're doing, and take an assessment of essentially what it is that we see and what it is that we're developing, even if you just look in kind of locally here in the TMC. So data, information, knowledge for scientific inquiry, problem solving, and decision making to improve health. And so I took a look across the researchers, the payers, and the patients, so the typical categories of informatics users or within the healthcare industry. And if you look at the tools that are available or that are being focused on nationally and in research, the clinicians and the researchers, I think, fare pretty well. About 80 to 90% of what I see is kind of in these categories where tools are being developed to support these activities. Payers, pretty much the same as well in terms of what they actually need to know. The bottom one is the 2 green X's mean that they don't really need to know that as much, and that's okay. And then the red one at the bottom means, hey, yeah, they probably do need to know a little bit about decision making to help with this whole value concept that's out there in industry right now. So a big focus nationally with regards to policy is how do you drive value in healthcare? But then when you look at patients, there's really kind of, from my perspective, and even in terms of what I've seen at MD Anderson, a pretty, a void in terms of the tools that are available for those individuals. So I think there's some academic incentives or priorities, policies that we could use to kind of fuel focus in that area. And I saw you shake your head there. You have a question? Yes, sir. So why is the ad for patients really important? So why do I think all of this is important? There's a sign that I passed by when I walked over here from MD Anderson that says 50% of all cancers are preventable. Do you guys know how many people died from cancer in 2015? About 560,000 people. So it's a little more up from these numbers, which were 2009. And so the estimate is about half of those cancers are preventable. So we dump a lot of money into research to kind of cure cancer once people have it, but not as much, obviously, then to actually prevent disease. Now, we do have a cancer prevention, but it's funded just like everything else these days. Anyway, so the bottom line is that cancer is preventable, and information technologies, I think, can be used to support that prevention. And I'm not talking necessarily just things like you might hear about, like persuasive technology, but things to help educate and guide people as well. So how do we translate then the federal policies to things that we might want to do at the academic level? So you're going to see these again, same items, and I think it correlates really well with where we probably need to try to focus academically, and that's from to collect to educate, from share to visualize, and I'll explain a couple of these, and from use to coordinate and collaborate. So what does that mean? And so some of you may know what this is. You may have seen it. So it's a tool that's being developed actually by Sriram Iyengar and a team. Sriram used to work here. He was my advisor for a while. He now works at A&M. And so he developed a tool called GuideView, which is when I start talking about patient education or our ability to interface with cancer patients is really important. The ability to give them the information package that they get right now in a much more digestible form. This is a really nifty IT solution. And the reason I really like this one is because it does not require the people that have to use it, and that's generally the operational miss, is they're not software programmers. So you want people to have the flexibility to be able to modify and change these things to adjust to the treatments that are actually being given and the things that the providers are doing on a more regular basis. And so with drag and drops on a process map, essentially you can create these tools. So we have something called a MEDACI, which is the MD Anderson Symptom Inventory, which tries to get an overall feel for a patient's functional status. So we're not just trying to get their opinions about how they feel, but something more measurable. And so within about 5 minutes, I was able to generate those MEDACIs in this form. The same is true about the ability to visualize. And so I want to do this part by asking you guys to raise your hand. So how many of you actually have an electronic EHR, personal record of your own in an EHR somewhere? Raise them really high. Okay, so let's keep them up though if you don't mind. So for those of you that have one, when was the last time, have you looked at it within the last year? Okay, so just a few people, and this is kind of the point of my whole area of interest, is the fact that the people really aren't using it. It's for providers typically, but there's some extreme benefits if we can get people to actually go do certain things. I look at mine all the time, so this is my version of EHR. It's blurred because this is my real health data. And the interesting thing about it, and I know we have folks in here that are interested in the visualization, one of the things that I as a patient like to do is take my data, and I have it probably over the last 20 years. We were required to have it at NASA, and I have it in digital form. But the point is, I want to go take a look at a patient to see whether something is going out of limits for myself. And I can't do it in the EHR. Personally, I have to go look at this. Even though it's electronic digital data, there's no method in the tool for me to go plot something visual, which is generally, as we all know, where cognitively people are going to pick up changes and things much more quickly. So again, from the patient perspective, it would be very nice to take this information and adjust or modify an EHR to actually be able to let patients use it, because again, that prevention piece is really so important. And then the last one, and this is the area of my research. This was kind of a snapshot out of my State of the Science paper, is a tool that I began to develop. It's actually one that I started to develop at NASA that we use for certain things, but I saw that it was going to be very applicable to healthcare. And I'm not going to give a lot of details about it because there's some things in here that, but anyway, the idea is to do something called process-based decision making. And the idea is to be able to collaborate, collect the patient's information, collect provider information, and store it and save it logically so that when somebody has to get a good feel for what has happened in a given cycle of care, it's very easy to do. And again, it goes back to that whole thing I talked about asynchronous capability with regards to the space environment. And I think something can be very appropriately done here. So the challenge, though, from an IT tool development is most of the folks that I interface with regards to Epic and EHRs, I haven't found very many physicians that actually like it. They really tell me that it takes so much time away from their interface with the patient that now you have this whole new organization of scribes that are going to be out there actually trying to take notes and so forth, when there's a much better way to actually do the EHR. So my challenge to us as informaticians is to not just assume that the EHR, the Epics, the Cerners or whatever right now are the version that we ultimately really want. Now I think is really the time to begin working on the version that is actually going to provide the benefits we want. But that really requires then that we do things like user cases, which we learn about when we first start, our courses, but we don't typically see a lot when we're doing development. So how is the thing actually used in practice, and to make sure that you integrate those things into the tool when it's designed and built. And so that's the intent here. And then all of this to say again, there's been surveys of the kind of the national landscape of doctors, and this is just one chart out of a package of about 100 that characterize the national landscape. And doctors are saying things about the EHR, but they're also saying things about the ability to keep it maintained and to transfer knowledge to patients. And so I thought this was a really interesting chart that says, doctors say patients updating personal medical records helps patient engagement, which again kind of goes back to that topic I talked about, and you can see the numbers. So again, if the intent is to really engage patients in their care and improve that care, it's things like this that we really need to pay attention to. And so this is pitch 1 of 3 as part of the PhD. We have to give 3 of these talks. This was more just of an introduction to my areas of interest. But I did want to point out, this came out yesterday. So it may have come out last week, but this is the American Association of Clinical Oncologists report on cancer care in America for 2016. And I just want to point out a couple things. So this was just out yesterday. You can download it and read it. But at the bottom down there, it talks about patient-centered care is the focus of virtually every alternative payment system and has never been more important. So again, tools and things to focus on patient involvement and decision-making. You might find it very interesting that about, I think 70% of Medicare spending is spent on about 10% of the care population, and about 40% of the Medicare spending is spent on people within their last year of life. Okay, so those are just things to remember. And part of the reason to remember it is because patients ultimately have to make better decisions, but they have to be, patients and caregivers have to be better informed about how to make those choices. Over at MD Anderson, there's one patient outcome that I tell people not to forget about, and is that patients want to be typically cured, but patients also view not going bankrupt as a positive outcome. And so again, that value statement is really important. And you can only do that if you're knowledgeable of the choices that you're discussing with your physician. And then the last one down there is our investment in research can only pay dividends if high-value care, if the infrastructure is there, to administer it or deliver it. And then just lastly, a few comments from later on in the report. It says precision medicine offers notable advantages of patients in need of extended treatment options, but however, patients and physicians are struggling to manage overwhelming amounts of information about risk and benefits of genetic testing and its role in selecting treatment. So again, it's not just patients, and so the area of interest for me is how do you effectively engage patients in an intelligent discussion with a clinician when the clinicians themselves are having a hard time keeping up with that information. And so again, the tool and the idea is to engage the patient and the physicians and the whole medical team in much more of a collaborative discussion of how these things work. So I'll give you a little bit more of that. So as part of it in the tool is you go to your physician and you have a bunch of questions. Generally when you go and you're talking with your clinician, they don't have a lot of time. They don't really want to spend it to you. they really can't. So how do you get your questions answered? And so you can envision an EHR that's designed such that the patient can actually enter questions kind of within their environment. Those questions are communicated to the physician automatically using the IT tool, and they have a chance to either the physician or their staff can review those questions and either answer them or be prepared to answer them before the interchange occurs. And all of it can be integrated into kind of a process-based tool that allows you then to capture the entire asynchronous activity. And then finally, aging population, number of patients is really going to increase, and it's much more complicated than even the precision medicine focus on one disease, because most patients are going to end up having multiple kinds of chronic conditions. So they're going to have to make more and more judgments about what kinds of care they're going to receive. And then as part of this then, so we'll have another pitch, and then the third one. And then for me, that's really the end. And I did want to just thank MD Anderson for kind of sponsoring my PhD effort. Again, they have an educational program and they're funding this. And then the SBMI faculty, so I've had quite a few courses that I really have enjoyed for the knowledge transfer this far. And then Dr. Ishii for the great policy class last semester, which I had never taken one, so I really did enjoy it. I think it's important for informaticians to actually take those as well. And with that, I'm going to open it up for questions or comments.
Dr. Ishii, any comments?
Dr. Ishii, are you there?
Questions?
Well, John, you covered a broad, broad area of informatics, but trying to focus on some depth here. You talked about policy development in health informatics. You then went into some other areas, but back to some policies. Your interpretation of a policy was not maybe the classic organizational entity that defines, the behavioral expectations and procedures within its care community. Back to the policy discussion, are you imagining policies institutionally? And what type of policies then lead to the adoption of what you're proposing in terms of better care collaboration and communication?
Yeah, so I'm thinking about the classic version, so the one you mentioned where, the academic institutions here within the medical center can kind of take a look at essentially where the weaknesses are in healthcare and then focus either degree plans or parts of, even a PhD or a dissertation has to include, maybe there's a requirement that includes an operational usability component. And that operational usability component can focus on the clinicians, but it also should focus potentially on patients. When you go look right now at the SBMI faculty, very few people are focused on what I consider operational kinds of implementations. It's just, the pure research. We have a few now that are coming in. And of course, I've seen you, I think, in some presentations as well talking about this. But to get students more engaged in it, I think there has to be much more of an awareness of the need to do that. And that those kinds of things are typically only done through policies, the same as what the government is doing with policies for EHRs. In fact, in this report, it says that one of the things that people would like to see the government get away from is forcing people to use EHRs. But then the question is, from a policy standpoint, is who then requires that people go do that? You have to have some business case. You have a look on your face there again?
I have all sorts of looks.
Okay.
So, distinguishing statements that may very well be true from research questions. So I'll go back to your first slide. It looked like you were riding a motorcycle there. So perhaps many people would agree that wearing a helmet is a good thing, and helmets should be more comfortable. Okay. Can you help? That's different from, for example, a research project focusing on the type of helmet that prevents the most injuries, for example. Or designing a helmet, which would be more of an engineering project rather than a research project, designing a helmet that would be more comfortable, hot weather, whatever. So, please correct me if I'm wrong, I did miss a few minutes, but correct me if I'm wrong, but it seemed like most of your presentation was of the former variety. strive to promote these good things. What's the research question?
So I did cover the research question. I think you might have stepped out when I did. So the research question was, no, you didn't, because I covered it. It was, you know, how do the concurrent, the combination of design dimensions affect patient and provider decision-making in the clinical environment?
So is there a hypothesis there?
I'm sorry?
Is there a hypothesis there?
Yes, the hypothesis is that, you know, if you design the tool effectively, it can minimize bias and enhance care collaboration.
Okay. I think maybe you and Dr. Ishii may want to discuss.
Well, so Dr. Ishii is not my advisor. He was the mentor for this course.
You
But,
and your advisor,
right,
fair
right.
enough. You and your advisor may want to discuss what is a testable hypothesis and what level that should be articulated. So I guess I would argue that if you design the tool effectively, it's not a testable hypothesis.
Yeah. So I understand where you're coming from.
Following up the research question, test hypothesis, it comes back to this applied question that I have, which is, when you're talking about patients, and I see patients, in a sense, they're a free agency, right?
Mm-hmm.
We don't control them. They control their own, you know, beliefs, thoughts, actions, behaviors, and all that. But you seem to be saying that there's a policy component that can enhance the doctor-patient communication. One element is effective tools, EMRs or not EMRs or websites or whatever.
Mm-hmm.
Okay, that's a tool component. But back to the question of a policy component. And the thought that a policy around that collaboration will help enhance and drive that communication. Just give you some examples of a policy, like when we do med administration, it is the policy you must mark that the patients are made.
Mm-hmm.
So heading down a policy, which is a prescriptive behavior that you expect from the actors in your entity, once again, where would that policy impact providers and or patients? I think patients are often going to be the hard one. I mean, you say, well, if we're under an insurance plan, the insurance plan may say, as a member of our insurance plan, if you want to get paid for your care, you must do the following: get a physical exam once a year, do your screening. You know, but anyway, back to the question of policy being the framework for which these tools and actions take place.
Yeah, so I think I probably connected two things that I didn't intend to focus on as much. So my area of interest is really about that patient-provider encounter and how we can use informatics tools to allow patients to be able to make wise choices about their care. I can tell you already, just in terms of my interface with the community here at this school, you have a very hard time getting people to focus on the patient as an area that actually requires informatics tools to be developed in. And so that's the whole intent of the policy piece, is to say if patients really are important to increasing value in care, is we have to do some research around how to include them. I mean, we had a presentation here about a week ago from the Texas Medicaid area, and they kept focusing on patients and patient involvement in care, really being able to create significant value in healthcare. Now, when I posted them on it, they couldn't give me any real good, answers to what that meant. I mean, obviously, if I could come tell you that, hey, having patients involved would take 20% of healthcare cost out because they were making better choices, then yes, it would be something I could convince people of to go do research. So that's the challenge, and so my challenge then is to be able to convince people that patient involvement in their healthcare and decision making based on their preventable chart is important, and then how do I translate that to the academic environment so that people drive policies that make it a little bit easier at the academic level for people to do a research project in that area. I mean, most people want to do a heavy, precision medicine or at the detailed basic science level research project. Nobody's really doing the research in this other area in terms of patient engagement involvement. But again, I think the academic policies are
You're just getting started, because I think there's an enormous amount of research in this area with patient engagement involvement. If your question then becomes, what are the tools to help enable that with policy?
But tools, I would make a distinction, so tools.
You make that clear distinction about it,
Yes.
because, once again, policy typically is the directives, prescriptives on actions and behaviors of actors within an entity. And that's exactly what I heard. informatics tools and user-centered design, all that sort of stuff, what do you do in the communication collaboration? Clearly, the better we can do that, the more effective we can have our patients involved.
Yeah.
So you want to focus.
So my focus is that last piece.
Okay,
This policy piece was, again, just, he keeps having to make these things
that's what
like.
maybe was a little.
Right. So one very, very interesting area that you may or may not fit into the domain that you're outlining, because I'm still a little fuzzy about the domain, relates to the healthcare costs that you mentioned, and particularly statistics regarding end-of-life care. So, and of much interest, of course, in MD Anderson. So, what can we do? I don't think you're going to get anybody to challenge the assertion that patients should be involved, or that patients need better information, or and that there could be theoretically tools that would meet patient information needs. I don't think you're going to get a lot of pushback on that. Very general statement. But you need, but as we discussed, you need a much more specific testable hypothesis. If I provide this kind of information in this way to these people at this time, X will happen.
Yeah, so I don't want to give you the wrong impression.
So, end-of-life care. So, with particular, so as you mentioned, there's a lot of futile care. There's a definition of that.
Yeah.
There's a lot of potential waste, suffering,
Right.
that may be avoided. Cancer is actually a great domain to study this, so this plays well into. So a project focusing on informatics support, and by the way, this is not a green field, there's lots of work in this, but a project focusing on provision of specific information to specific patient populations at specific times in specific ways, and measuring the outcome on, for example, DNR, DNI orders, chemotherapy, involvement of palliative therapy, a duration of life after a certain point. That might be an area where you could focus this kind of project. Does that make
Oh, it
sense?
does. So what I was going to say is I don't want you guys to get the wrong impression. So part of why this is the way it is this one kind of one of the first presentations or areas that I've done on this. And getting that partnership with a faculty member to be able to outline those is part of what I've kind of hoped to get out of this, is to help focus me to those next areas. And I've had a hard time with that so far.
We're trying.
Yeah. But no, this is good. So that was the intent of thinking about conceptually, was the starting question, at least generally, an area to begin thinking about, and then how to drive that down to something much more specific.
So it doesn't sound to me like you're interested in policy.
No, and that's the part that I probably confused here, is I'm very interested in a certain area where I just don't get a lot of traction in terms of people's interest in it, and I think it's very important to the outcomes or the things that we do in healthcare, and I just don't see regardless of whether there's people like you guys are talking about that are focusing on the area, I don't see it at MD Anderson in terms of the things that patients are using or getting. So I'm kind of in between, and in my prior life I was as well. So I was kind of in between the academic and operational. I could see this void of things that weren't being focused on, and it's hard to convince people that it's important to focus on them. But I honestly think it's the only solution to solving the value issue in our healthcare system. I'm sorry.
As you're doing your PhD and doing the thousands of hours of literature reviews you need to do, you will see, I think there's a rich diversity of research in this area, from social sciences and medical anthropology, medical sociology, public health. It's all out there, and your premise is correct. Patient involvement, engagement is critical to better outcomes. I don't think that's a question of research.
Elements are good.
Yes. Okay.
But then it's the next step.
What
tools
specific?
You provide, what are the attributes of the tools, usability, convenience, all the kind of things like that make it easy to adopt and use.
Yeah, so I'm not going to respond to that because I agree, other than to say I agree with you fully. That's where I'd like to go.
We will see.
Yes.
All right.
So are you actually, learning from already existing patient communications at MD Anderson?
Yeah, so that's what I do as part of my job. So I get to sit and hear patient encounters and The enhanced surgical recovery is interfacing with the patients to understand patient needs. We did something called an Arthur Vining Davis Foundation study here recently, and it was over like 5,000 patients. And people tend to think that the number one outcome that people focus on in cancer care is curing their cancer. But after a couple of years with cancer, people actually do not believe they're going to be cured. And so their focus switches from cure to, something different. Not even palliative, but just quality of life in a time frame. And that was very surprising to us when we saw it.
Well, there's a lot of studies, and we're no longer trying to cure the cancer, we're trying to cope with living with cancer.
Yeah.
So I think you had a slide about genetic studies and patient decisions. Is that an area where you're taking a poll, like,
Oh, not right now, not in my current work. So actually, my work is much more basic than that. Again, that's the void between what research is doing and what actually happens in practice. So what we're doing in enhanced recovery right now is just trying to minimize the surgical stress. The stress is associated with surgery, and it's not anything heavy basic science. It's just really common sense things. Like, if you were to go out and run a marathon tomorrow, would you starve yourself the night before?
Well, this is pretty major in terms of surgery, right? You go get a genetic panel and you say, oh, I'm going to have a unilateral versus bilateral mastectomy.
Mm-hmm.
That's a surgical outcome.
Yeah.
So it's kind of important to look, I guess, at some of those.
Oh, I agree with you downstream, so I'm not going to disagree with you. I'm just saying that the issues that we're dealing with right now are much more basic than even, that. That's the point. So, any other questions, comments, thoughts?
Any other questions? All right, thank you
All right,
very much.
thank you. Yes. Hey, how are you?
I just want to say hi to you because I just had the interview with Alex.
Oh, you did? It was over at the, okay, you're Chain Lane, behind?
Second floor, I think the
Yeah. How
open area, but it was a nice conversation, very.
Oh, good.
I enjoyed the conversation.
Good, good.
And she asked me if I had an opportunity to talk with John at SBMI because he's from SBMI.
Yeah.
I said no. I saw the gentleman many times in the seminar. He's very active in academia research, but I didn't get a chance to talk to him.
Yeah, no problem.
I guess it's my first chance.
No problem. Yeah, I think I've seen you here in these sessions as
Right.
well. So, are you a new student or you been here for a while?
I've been here for like 4 years.
4 years in master's or PhD?
student. I'm
Were you in
a
the?
PhD
Oh.
candidate already.
Oh, okay. So you weren't in the session with Dr. Finley because I just started about a year ago. So.
Right.
Yeah. Okay.
And you said you are also working on a PhD program?
Yeah. Yeah. So I'm in the
And
PhD
with
program. I'm sorry.
with which department?
The SBMI.
Oh.
Yeah. So same.
So,
Yeah.
okay.
Yeah. So I'm the same program you are. You're just ahead of me.
Yeah,
So,
right.
Yeah.
Right,
Who are you working with?
Dr. Gong.
Yeah,
I work
yeah.
with medical arrow and also
Yeah, sure.
for the natural language processing.
Yeah, I want to work with him as well, and hopefully Dr. Langabeer.
Okay.
Yeah.
Nice.
Yeah, he is. But very nice to meet you, sir. How'd your interview go? Though? Went okay?
Yeah. Are you heading back to work?
Yeah. I just walk street.
Right.
Did you walk over there, or did you?
Many times.
Okay. Yeah. I just walk back and forth.
Right.
So have you done your a couple of these presentations too? Have you done any of the presentations for
I
these?
have a presentation like next week and at San Francisco.
Oh, when?
After
Just
you, sir.
go right ahead. Coming soon, or?
And I also have a presentation for the my seminar next month.
Oh, do you? Okay. Will be your first one, or?
I've done by many times last year, every semester.
Oh, good.
Or, yeah, you come in, by the way,
Yeah.
if you have already decided what you're gonna do in your new
Right,
job,
right,
congratulations.
Right, right.
Wait, I'm thinking, oh, we hired you from
Right.
California or
Right.
Boston, and,
Right.
no, here's how it's gonna be.
Right.
It's a little weird. But,
Right, I agree, I agree.
So I think, I would respect the person in that position to say, I guess, a little bit flexible, understanding that person may come in and want to do things. But I think acknowledging that that role is a critical role.
But would this be a tool for that person to utilize, or would this be something that person's kind of in charge of?
Well, so I think that's a great question. So traditionally, system has not been a top-down, dictatorial, hierarchical.
Okay.
You know, so I have not seen, and maybe I'm just ignorant, but and maybe I'm not aware of certain projects or what have you. But I haven't seen Hetty Hearn leading a project.
Well, I really liked your insight when I said, we got no direction.
Yeah.
You were saying, well, that is direction.
Yeah. Yeah.
That means we are in charge.
Right.
We do it.
Right.
I didn't even think of it that way, but I'm a little more comfortable with somebody saying, go do the following. bam,
Yeah. No,
go do
that's
it.
not.
Now, that doesn't mean that the new person in that role,
Will behave that way
I gotta just tell you, most data warehousing, data analytics people are control freaks.
for obvious reasons.
So I suspect we're gonna get somebody in that role.
But we don't know that this is going to be a data warehousing person. I have no idea if that's true. I have no idea.
You know what
if
I
these people are.
realized, I haven't even read the job description. Did you read the job description?
I glanced at the job description a month ago.
Why didn't you want the job? You know you gotta live in Houston.
I don't want to be in system.
But wouldn't that be more of a political role
Yes.
than
Yes.
an actual?
So traditionally, the system has seen themselves as facilitators. So for example, Ken Shine.
Weird.
You know who Ken Shine is?
Yeah, sure.
Yeah.
Yeah.
I mean, not.
There's human guy.
What? Yeah.
There's human.
Yeah. I mean, not a minor figure in
No,
American medicine,
no.
right? I don't know that he led projects at institutions of this type.
Yeah. Well, that particular role, the Chancellor
Right.
of Health Affairs, is
Or anybody
different than.
under.
Oh, okay.
I mean, so maybe David Lakey's stuff will be different. I don't know. But traditionally, I guess I have thought of system as preferring to be in the role of convener than in the role of leader.
Okay.
Traditionally, the campuses have been quite strong. System has been weak in terms of exerting control. So, but I think you're raising a very important point that I don't have an answer to, or a very important question that I don't have an answer to, which is what will be the role of this person in this project? I don't have an answer to that. I don't know.
So what you realize is it changes the, the direction becomes, excuse me.
Hello? Yes. Yes, ma'am. Yes. Yes. Uh-huh.
This poor guy. This poor guy was left to fend for himself. Presenting. Well,
All right. I come here some days, we have no lunch, and then I come, we have 35 weeks of
so I got the usage numbers for studies from San Antonio,
Fantastic.
but not some Western, some,
Somebody had to say anything.
just a couple.
What, we mean two, or?
No, like 5